All right, this video is going to be a revisiting of immune checkpoint inhibitors. I'm going to do a quick recap of a checkpoint inhibitor, PD-1, PD-L1 that we've talked about before, and then use that to segue into a relatively newcomer to the immune checkpoint therapy for cancer that's in development. It'll make sense in a little bit. So as a recap, PD-1 and PD-L1 are a receptor ligand pair, right? PD-1 is considered the receptor and PD-L1 is considered the ligand. And it's an immune checkpoint inhibitor, meaning this T cell is going around screening human cells throughout the body to look for any that are damaged, that have obvious problems, that are expressing novel antigens that make it seem like they're either infected by a virus or they've developed mutations and are becoming cancerous. So this T cell has a receptor that recognizes antigens. Specifically, it recognizes novel antigens, something that doesn't normally belong inside of a person. That could either be a fragment of a virus that's left over when this is a virus-infected cell, or it could be a mutated human protein, because we know that tumor cells accumulate mutations, which will slightly change the structure of proteins in those cells. Those become antigens. So the more of this antigen is present, the more this T cell will want to attack and kill that tumor cell, which of course is a good thing if we're trying to prevent cancer. The tumor cell obviously doesn't want that if we anthropomorphize a tumor cell. And so they often express PD-L1, which is an immune checkpoint inhibitor, which effectively tells this T cell, look, I'm a normal, healthy human cell. You can leave me alone. I'm not something foreign. And normal cells express relatively low levels of PD-L1 as a way to signal to the T cell that they're healthy. Tumor cells will upregulate PD-L1, make a lot of it, more than a normal cell would, as a way to try to force the T cell to back off, right? So when it comes to cancer treatment, we can design drug therapies, often antibodies, or protein molecules that either bind and block PD-L1 or PD-1 directly and prevent them from interacting with each other. And so we've got this push and pull where the T cell receptor binding the antigen is like the gas pedal that fuels the attack. And PD-1, PD-L1 is like the brake pedal that prevents T cells from attacking, right? So by using either of these drugs or both in combination, we're effectively taking the brakes off of the T cell and giving it more of a license to go hard after those tumor cells and not turn on that immune checkpoint. Okay. So a lot of different therapies have been used to target these immune checkpoints, right? You have antibodies that bind PD-L1. You have antibodies that bind PD-1. There's also another set, the CTLA4, B7 interaction. You can use an antibody to block that. And that brings up the point that immune checkpoint systems are complicated. There's more than one receptor. There's more than one ligand. And the variable part of this is different tumors in different patients and even different cells within the same tumor might express different combinations of immune checkpoint proteins, right? One tumor cell might have a PD-L1 overexpression problem, and another might have, a B7 overexpression problem, and another cell might have a combination of the two. And it turns out that there is another player in all of this. So the new target that we're looking at, which is, being pursued by this new company, NextPoint, which was founded by Gordon Freeman, a researcher who is effectively considered the maybe not like initial discoverer, but certainly his research lab elucidated the function of this new immune checkpoint receptor, B7H7, also known as HHLA2. Those are synonyms with each other. And so this B7 receptor family includes a handful of different components. So PD-1 is a receptor within the B7 family. HHLA2 is another member of that same family. And the concept is fairly straightforward. The idea is that HHLA2 functions in a very similar manner to PD-1, and they're redundant in some way that they both can activate immune checkpoint inhibitors. Now, the fine details of why do some cells produce HHLA2 and others produce PD-L1, well, that's not entirely clear. All we really know right now is HHLA2 is similar to PD-L1. Its receptor is a protein KIR3DL3, very cumbersome. But the end result is effectively the same. If the tumor cell upregulates its production of HHLA2, right, that's the equivalent of PD-L1, same concept. And these natural killer cells or T cells, which are the cells that are hunting our tumors effectively, they have this KIR3DL3 receptor, and if there's increased binding of HHLA2 to those receptors, you inhibit or shut off those natural killer cells and block their secretion of cytokines, right, that stimulate other natural killer cells and T cells and attract them to the tumor. And so fairly straightforward, if we want to design drugs that are going to impact the system, just like PD-1, PD-L1, you could imagine antibodies that bind and block HHLA2, and you could also imagine antibodies that bind and block the receptor, or using a combination of both. Right? So that seems to be exactly what NextPoint is trying to develop. So they illustrate two different antibodies here, one that blocks the receptor, and these, so NPX267 is just their working name for that drug, which is a monoclonal antibody, or this other antibody which binds the HHLA2 ligand itself, and I'm sure they'll have to be tested individually, eventually probably in combination. And it seems like the place where this is going is in some patients, the PD-1, PD-L1 blockers work very, very well. In others, they don't work so well. And it seems like their hypothesis is this may be the missing link that explains why some patients respond well and some don't, that if a tumor cell expresses PD-1 or PD-L1 and it also expresses HHLA2, then you might have to inhibit both of them to effectively get the job done, right? And what they're doing is, in addition to developing those antibodies that are going to be used as medication, they're also developing biomarkers, meaning using antibody stains from tumor biopsies in patients to determine which patient tumors have the highest expression of, remember, B7H7 and HHLA2 are the same thing, right? And so the strategy seems to be, we're going to take tumors out of these people, we're going to test them for HHLA2 and probably for PD-L1 as well, and find out what immune checkpoint inhibitors they produce at the highest levels. And patients that have high expression levels in their tumors of these immune system inhibiting ligands will become the patients that are most likely to respond to those therapies. And that way you can customize which patient gets which set of drugs. Right? And so to try to dig into that a little bit more, I found a review that was effectively covering this HHLA2 or B7H7 in human cancers. And there's no reason to go through all of this in tons of detail, but they collected data from publications in the last handful of years for a lot of different cancer types. And we're trying to basically make a database of which cancer types are most likely to overexpress HHLA2. And it turns out that a lot of different cancer types are known to overexpress that ligand, but it's pretty much never 100%. And so the fact that you have 40, 50, 60, 70, 80% of tumors overexpressing means that there's a high potential for this drug, because a lot of patients and a lot of different cancers show overexpression. But since it's not 100%, you need that screening procedure, right? That's why this diagnostic tool is probably fairly important to their success. Is you don't want to go wasting your time giving to this drug to patients that don't overexpress your target. And so we'll basically be filtering patients through this screening process. And then if their tumor shows overexpression, then they will get one or both of these antibody medications. And it seems like clinical trials for those antibodies is where we're headed next. So it seems ripe for a follow-up at some point, and hopefully we'll have more information by then.